Thank you, Tim, for coming over today to the UK and for giving this talk to the Health Foundation. A big welcome.
Thank you.
You are a practicing clinician at Partners Healthcare in Boston. You are also the lead of the Pioneer Accountable Care Organisation and also the Vice President of the Population Health Management at Partners. Can you say a little bit about Partners and also what the ACO actually is?
Sure. Well, first of all, thank you for inviting me. It's a pleasure to be here. So Partners Healthcare is a large integrated delivery system. We have two large academic medical centers, Mass General and Brigham and Women's Hospital, two approximately 1,000 bed hospitals in Boston. And we also have a number of community hospitals, a psychiatric hospital, post-acute facilities like rehab hospitals and nursing facilities, and a home health care agency, as well as about 1,000 primary care docs spread out throughout eastern Massachusetts. So it really sort of is a delivery system that has all the components necessary to provide the full range of care. So that system existed for the past actually 20 years in a fee-for-service system, but as our growing problems with the cost of healthcare have moved in the United States have moved us to change our payment systems. And the payment systems, the code word is Accountable Care Organization. So we signed contracts to become Accountable Care Organization, which means if we can keep the growth of costs for a defined population below a benchmark, in this case it's the average cost increases for all Medicare beneficiaries in the United States, if we can keep our costs below those costs for the people we serve, for the patients we serve, then we will share in some of the savings. And that's the basis for the Accountable Care Organization contracts.
And what would you say your priorities have been over the first couple of years of this pioneer status? And how have you gone about trying to achieve those?
So I would say our number one priority has been to explain to absolutely everyone in the organization, from the board in the very top to the people who empty the dustbins, why it is we're making this change, that we need to be part of that healthcare cost inflation is bankrupting the United States as it is many other countries, and that we need to be part of the solution. So I would say the first thing that we started to do and the thing that we continue to do, communication, because it's very, very important that everyone in the organization own this process, be proud of this process, and go through the process with it. Because frankly, it's a big change, and we're going to need everyone to be on board with the change. So I would say communication is number one. Number two is we have to reorganize ourselves. We were organized to exist in a different set of circumstances, and now you have to decide what is the governance, what is the oversight, how do people relate to each other now in this new payment system. So there's oversight and governance, organizational changes. There's a third bucket, which is how do the financial incentives and how does money flow through our system. That's a big change. And then the most exciting part for me is where are we going to make investments in the improvement of patient care that actually reduces healthcare costs. And that's the part that I think gets most people excited, because we're doing the kinds of things that you would want your mother, or I would want my mother or father treated under this new system of care. And I would say we're very early on. You asked how far we were in that journey. We're pretty early on. We have some definite successes that we've quantitative successes, like measured successes. But I'd say in this early phase, the best successes we've had are the stories from our clinicians and from our patients about how they were suddenly able to do something that they've always wanted to do but couldn't do because of the way the barriers to getting it done because of financial incentives or structural issues.
So payment incentives, targeted investments, and communication seem to have activated some of the clinicians. Is there anything else that you have been using to try to change the culture, overcome inertia, that you could say?
I would say I'm very blessed to work in an organization that is committed toward science and evolving the knowledge base. And a lot of the things that we're doing, we don't have the right answer for. And so if we design what we're doing in such a way as to extract knowledge, actually create an experiment or a pilot that we evaluate, we've generated quite a bit of excitement, even in the individual, say in cardiology or rheumatology or cardiac surgery. We're studying as we're making these changes, and that studying part of it is in my culture, the culture of my organization, is an enabler because there's a real intellectual curiosity about how much, if it's better, how much better.
So there are 23 ACOs across America, pioneer ACOs across America, and the first 2 years of evaluation showed that overall there were some modest savings, but they were concentrated in 9 out of the 23. One of them was partners.
Yes.
Can you say a little bit more about the impact that your efforts to date have had on cost growth, and where in care those cost savings have been realized?
Yes. So the cost savings have been primarily realized in hospitalizations for our Medicare beneficiaries through our care management program. This is a program where we identify the highest cost patients. We assign them a care manager, a nurse, who gets to know them really well and is also embedded in the primary care doctor's offices. We now have 100 of these care managers set up with primary care doctors and assigned to, it's about 200 high-risk patients for each nurse. And this program delivers a return on investment fairly quickly, so over a 3-year period. And that's been the earliest success of the program, which has clearly brought hospitalizations down among that group. We have a lot of other programs where the return on investment is going to take longer. And that's one of the more difficult things about these arrangements is that most of the time we write these contracts to get a return within 3 years. And that's hard to do in large organizations. My preference would be to have to be accountable over a 5-year period, but just contract cycles being what they are, it seems like most of the contracts are written in a 3-year time cycle.
And have the savings been concentrated in the bigger medical centres versus the array of other providers that are affiliated with your organisation, some of which are actually very small?
Yeah, no, I'd say it's not just isolated to the large academic medical centers. There is a big reduction in costs when you decrease hospitalizations at the big academic medical centers. But the costs in a commercial, in a younger population, in an employed population, are largely outpatient costs, and those costs are mostly in the community. They're not in the big tertiary academic centers.
And how far have your investments been targeting population health, or indeed social care, so factors wider than the healthcare system? And if so, how did you even build up a business case to prioritise that area?
Yes, that's a tricky question. So the United States in general funds a lot of interventions through healthcare that most European countries fund through social care. So there's a very different way we think about or allot the dollars. And without making a statement about which one's the right way to do it, what we end up doing with our nurse care managers for our sickest patients is doing an enormous amount of social care. So we are in the homes. We are dealing with rugs that they're likely to trip over, or bars in the bathrooms, and transportation issues, housing issues for homeless people, a lot of stuff. which would normally you'd think of as being funded under social care, we're actually, because we have an incentive and we know that those investments will actually end up decreasing their healthcare costs, we're actually buying a lot of social good for those selected patients that we're at risk for. Now, you asked another piece of this, which was, how do I convince people to spend that money? That's tough. So I will say our chief financial officer really wants to see return on investment calculations for everything we spend money on. I've been doing a lot of return on investment calculations, and some of these things are really hard to do. So what I've basically done at this point is do return on investment calculations for buckets of activity, and not sort of specifically if I were to pay for an air conditioner in someone's house, during the summertime, in an elderly person's house during the summertime, I can't document that return on investment. Although if we know that person has been to the emergency room 3 times with heat stroke, then I think you can easily draw the anecdotal conclusion. But I think as long as we keep monitoring what we're doing, and we have terrific data which allows us on a month-by-month basis to see whether or not our investments are paying off, that's critical to the CFO and approving these investments, because it's about controls, right? And we can see whether or not our investments are working in a near enough time frame that we can alter course if it proves ineffective.
Critical to the CFO, but also critical, I presume, to the head of cardiology, the head of neurology, who may be making savings in their service line only to see them going out of the hospital door into social care.
Yes, that's another good point. In some ways, what we're asking our physicians to do is cannibalize their own business, right? Is directly undermine their own business. And that's getting back to an earlier point about how funds flow through our organization. To the extent that the cardiologists are particularly successful at decreasing healthcare costs, that actually could be bad for our cardiology department, right? So we need to make sure that those savings that they're generating and that we're getting a piece of through our contracts get back to them.
Mm-hmm. Okay, that's useful. So could you, we in Britain are now having to live within a 0% real terms growth situation.
Yes.
Can you tell us what your rate of real terms increase is, even with these savings that you've managed?
Yes. So in our commercial contracts, we're at 0. So we're having to sign contracts. Now, we live in Massachusetts. Massachusetts is a bit of an outlier in terms of the U.S. on this particular point, because we're the only state in the country that has now a law on the books that says healthcare costs will grow no more than inflation. So we're saying inflation this year is 3.6%. So it's not just our contracts, it's actually the law that says we can't grow by more than 3.6%. Now, 3.6% is more than 0, but that's, we have, for example, 5-year contracts with our nursing unions that say they're going to get larger raises than that over the next several years.
Can you say something about the quality metrics and how quality has changed with being a pioneer ACO?
So, first of all, I will say that I'm very interested in quality metrics, but I always start talking about quality in healthcare by saying there are a few quality metrics, and then there's everything we do in healthcare. And those two things, one is a very small box and one is a very big box. And I am always careful not to equate what we measure with what is quality, because what we measure is actually very, very small. Having said that, we need to measure, and we measure a lot internally. We have literally hundreds and hundreds of measures of our doctors that we use internally that we don't publicly report, and they really shouldn't be publicly reported. But I get the point that the people paying for healthcare want assurances that we are delivering high quality care, and so there are metrics of quality. we do fairly well on those. I would hope that in the future we will move towards more outcomes-based measures, registry-based measures. You know, what my father-in-law, who's going to get a hip replacement next week, he asked me what I wanted to know about his surgeon, and I said I want to know what the infection rate is. You know, because that is and the surgeon he's going to doesn't know what his infection rate is. To me, that's unacceptable.
Okay, thank you. And final question from me really is that in this country we've got a very pressing financial issue and quality issue, and speed is of the essence. You've mentioned financial incentives and leadership and data, I think, to help speed up, and the patient, involving the patient to help speed up care, the quality of care. But I'm just interested in the role that you think that quality improvement methods have in and techniques have to try to improve the quality of care, whatever they are, whether it's lean or total quality management or something else. What kind of efforts have been made in partners on this?
Well, so I think they're very important. I think you can do top-down stuff, is leadership, communication, all that are important pieces, but you have to give the people at the point of care, at the sharp end, as they say, of care, the tools necessary to get the work done. And what I find so helpful about the tools, regardless of which one you choose, is that they provide people who don't do this for a living, who they actually deliver healthcare for a living, and quality improvement is not their day-to-day experience. It's a fairly easy toolbox to use. So you can pick the tool up and anyone can use it. And if you just sort of follow the step-by-step guide, set a goal, measure it, figure out what the deficiency is, improve it, measure it again, right? It's that process. And so we do employ people specifically to help our clinicians get involved in that process. And more and more we're actually including in our clinicians' incentives, compensation incentives, the need to participate in that process. And so we're not saying you have to make big improvements. We're saying you just have to participate in that process of continuous improvement. And I expect that over time that will become simply an expectation of working within partners, that part of your job is to do your job and part of your job is to try to improve your job.
Tim, thank you very much.
My pleasure. Thank you.